Hello, and thank you for the invitation to speak at PedirhythmX. I've been asked to speak about the safe management of patients with remote monitoring. Um, During the session, I was pretty amused that I was included in the digital health and new technology um, segment with Jen Silva talking about artificial intelligence and Nick talking about fancy new technology. I think you'll see during my talk that this will be decidedly more old school and less so about new technology. So I apologize in advance. So remote monitoring, why do we care? Why should we care? I think first and foremost, we of course all worry about patient safety and want to avoid events like this. Here's a 10-year-old girl who showed up in the emergency room with congenital heart block and a pacemaker, feeling a little bit tired, a little bit lightheaded, a little bit swollen. And you can see that her ventricular lead is firing, but is no longer capturing. Thankfully, she had an escape rate that was adequate enough to keep her upright. Fortunately, when looking back, it seemed that she had sent a transmission many months ago that she had shown loss of or intermittent loss of capture. And this was missed for a variety of reasons, which we'll talk about. We also don't want to miss events like this with this battery hitting end of life and not just ERI. We want to see sudden changes in the impedance trend of the leads. And of course, we want to make sure we don't miss any dangerous arrhythmias. Patient safety aside, remote transmissions are also better for the almighty dollar. This is a paper looking at a retrospective look at the Truven Health and Medicare databases, compiling almost 93,000 patients. And you can see across pacemakers, ICDs, and CRT devices that the use of remote transmissions can reduce all-cause hospitalization and also decrease the length of stay should you get admitted. Overall, there was a 30% reduction in hospital costs if you use remote transmissions, and you saved $370 million over 100,000 patient years of follow-up. Problem is transmissions, well, there's just a lot of them. This study here looked at 500 transmissions over 2 years. Of these, only 27%, and I think that's a decent number, had important events on them. Most of them, as you can see, are rhythm related, less so lead or battery related. They found that 8% of these needed physician input and only 4% ended up with a subsequent procedure. Looking at it from a pediatric standpoint, this study by Lindsay Malloy looked at 5 years worth of transmissions, 198 patients, 600 plus transmissions in total, and again found that most of these transmissions were rhythm related, again less so lead and battery related. 16% of them had clinically important events, and 11 of them prompted clinical intervention, 11%. Breaking this down even further, this nice study by Bryn Deckard and Martin LePage in Michigan looked at transmissions over 2 to 4 years, depending on whether you had a new or old device. 455 patients, over 3,000 transmissions, and broke this down into symptomatic and asymptomatic transmissions. The symptomatic ones, that's where the money was. 30% of them ended up in actionable events. You can see here, but this only made up 195 of the transmissions, so only 6%. The other 3,000 plus transmissions were asymptomatic, and unfortunately, this only had an action rate of 2 to 3%. So you can see from that study, there's just a lot of noise that we have to deal with. It's our job to pick up the tiny signal that pops through from time to time. Speaking of time, as you all know, transmissions also take a lot of it. Looking again at the Cronin study, they looked at actionable transmissions and found that it took 21 minutes to look at these interrogations. Makes sense, there's important data on that. But even for the ones that weren't clinically relevant, these transmissions took up to 10 minutes on average to review. So if you're getting hundreds of thousands of these transmissions, well, it's just, a lot of work, and you need a lot of help. And we're often buried under a lot of paperwork, or in these cases, digital paperwork. And unfortunately, there just doesn't seem to be an easy solution to this. Now, PACES did release guidelines to kind of help with figuring out when to see our device patients. For in-clinic visits, they recommended an annual visit. But for remote transmissions, there is still some variability to it, 3 to 12 months for pacemakers, every 3 to 6 months for ICDs. This survey done by Melissa Olin and Molly Shaw was done before the PACES guidelines were released, but just reflects sort of the variability in patient care. You can see for in-person follow-up, there's quite a range as to when patients came back. Same thing for remote transmissions, although there was more uniformity for ICDs, and also quite variability in follow-up studies in terms of echoes, stress tests, Holters, and chest x-rays. Also done before the guidelines, Byrne and Martin did this study as well, and they wanted to see how often transmissions needed to be sent. They looked at over 300 patients and asked them to decrease their transmissions from every 2 months to every 3 months. With this, they decreased transmissions by almost 300 over 2 years. And importantly, there was no change in the overall complication rate of their patients, nor was there a change in the action rate on the interrogations, staying around 4 to 5%. With that, I think it shows that more is not necessarily always better. And I think the next or subsequent study should actually look to see whether or not we can decrease transmissions every 4 to 6 months, compare that to every 3 months, and see if that makes any difference at all. What we also need is more organization. This report here looked at current and future models for evaluating devices, on top of recommending that we look at machine learning and AI, ways we can decrease just all the cognitive burden that we have from these transmissions. They also spoke about the benefits of an arrhythmia diagnostic center or middleware that can help manage data from different vendors, deal with scheduling, interface with our medical record, and help with billing. Now, there's been a lot of these middleware companies developed over the last few years, Cardio Diagnostics, Merge, Geneva Health. I'm not actually familiar with any studies that looked at the benefits of these vendors, at least nothing published yet. So please let me know if you know any differently. What I do know is that there have been numerous studies that have looked at the benefits of a dedicated device team. And what does this entail? Well, the papers talk about how you should have trained nurses and or technicians looking at all the transmissions. These people should have relationships with them. So you know who the patients are, you know how to reach them, you know what they've had before. This makes for a much more efficient system overall. They have physicians available only for alerts and consults. And then they also talked about patient contracts, ways to have the patient more actively engaged in their care. And this, unfortunately, then brings up the big elephant in the room, which is patient compliance, which we all have issues with. The study done by Cronin looking at adult practices found that 50% of them were non-compliant with their transmissions. A little better in pediatrics, 18% from Lindsay's study. Now that brings me to possible new technologies that can help with this, and also gives me an excuse to put in my obligatory Star Trek or Star Wars slide with every talk. As we all know, there are apps that are available to help with transmissions. This one here looked at 240 patients and found that 73% were compliant or adherent with putting the app on their device. Those that did in a follow-up of only 3 months found that the compliance rate increased by 99% in sending remote transmissions. Now, are there any barriers to sending these transmissions and using these apps? This study found that 89% of patients could use the app successfully, and there was no difference in terms of age or sex. One thing that I did find very amusing about this study was that there was no clinical numerical difference when it came to who could or could not use the app well. But statistically, it actually showed that people who were 60 and over were better than those who were under 60 when using this app, to which I say, in your face, millennials. Um, Now, are there any other apps or anything else that we can do to help with compliance? This gives me an excuse to talk about a QI project that I've been working on for the last 5 or 7 years or so in collaboration with NECA, or the New England Congenital Cardiology Association. This includes all these states here. We enrolled patients who were 21 years or younger. This involved 10 institutions throughout the New England area, and we found 660 patients first. We then looked through who was making it to their annual visits and found a non-compliance rate of 22%. And in terms of remote transmissions, they were non-compliant in 54%. So we started this QI project and had a dedicated person look to see who was or was not coming to their follow-up visits in person. They didn't show up, they get a phone call. They didn't come back in 3 months, they got another phone call. And for those that were non-responsive, they had a certified letter sent to their house. And so with this, our missing follow-up then decreased from 22% to 11%, then after a year went down to 8%. And that has kind of held steady over the last few years, with a little bump up in non-compliance rate for follow-up visits during the pandemic. Seeing this response, we thought then we would start tackling remote transmissions as well, and decided that education was a good way to start, telling them why transmissions are important, and then provided a postcard that I thought they could hang up on their fridge to remind them to send in the transmission. Unfortunately, I think this is where all the postcards ended up, since it didn't really have much of an impact on compliance rate. Then thought we would try something automated instead, and use the hospital's DISCO system, or a discharge coordination system. So patients actively agreed to sign up for this. And so every 3 months, they would get a text or an email that said, hey, just a reminder, send a transmission, it's important for your health and safety, please send this in. And unfortunately with this, the compliance rate still was not great. 44% were non-compliant. In fact, you can actually see the patients got the text, looked at it, and then did nothing about it. So we decided to go old school instead, and we just had some people call the patients. And so there's a dedicated person who would then see when transmissions were not sent in, and then call the patient. If they didn't send it after 3 months, they would call them again. And again, we'd also send a certified letter if we got through to them. Of the almost 100 patients enrolled, after the first phone call, a little bit of a difference, 55% were sending transmissions in. After the second phone call, the non-compliance rate went down to 11%. So I found that this had the biggest impact out of all the interventions that we did. I think it's just a good example that we just need a human touch to all of this. People definitely respond better to a person calling them than to an automated email. I think we sort of learned this during the pandemic too, that everyone's sort of craving personal interaction. Obviously not a highly efficient system calling every patient, so I think there has to be some balance of using some automation, but also personal phone calls as well. Now, the PACES QI committee is looking at ways to help improve remote transmissions. This is being led by Dr. Arti Dalal and Bradley Clark. There is a site on the PACES webpage that can help you get some information on it. And if you're interested, you can click on the link and then talk to Arti and Brad. If you are interested in being involved or become involved, you can also then have access to resources that hopefully can help with patient compliance as well. So in summary, this is how I feel. I think a lot of us feel when we talk about remote transmissions. But we do know the remote monitoring improves safety, patient safety and outcomes. We know that we need better systems to help process this important data. Patients can be non-compliant with transmissions, but I think old school and new school technologies can help with this. Thank you very much.